Hello and welcome to the Auditing Antics podcast. I'm happy to be back this week. I was out last week down in Florida. I got to present a couple of sessions at HealthCon for AAPC in Orlando, and then spend some time with family, with my parents, and also with Michelle, who lives down there. So happy to be back. And today we're going to be diving into telehealth. So I wanted to give a little bit of space before we tackled this topic here, just because of everything that's been going on as far as waiting to hear updates from what Congress was going to do and waiting for extensions and hopefully clarifications from CMS and those various things. So finally, we're at this point where we're going to talk about it. And I have up on the screen, if you're watching this on YouTube, Facebook, or LinkedIn, take a look at the screenshot that I have up right now, because I just want to remind everybody that if you go to my website on the homepage, stephanieallardconsulting.com, I actually have a free download there that is a summary sheet of what we're going to talk about today from the perspective of where the guidelines are at right now. And then I put together just a quick worksheet that you can use as you are researching. So one of the things that you're going to find is that today on this episode, as well as any other, session you attend, we cannot give guidance to every individual entity because it's going to depend on the payers you contract with, sometimes the states you're in, the regions you're in. So there is a part of this where you're going to have to, jump in and do your own research. So I created a worksheet there for you to use as a guide to hopefully help you with that part of the research. All right, now Michelle, right now, I feel still at this point, I would say overwhelmed with telehealth services. And what I mean by that, in my feelings of being overwhelmed, is that every single time that I work with an entity, whether it's a hospital facility, a single owner practice, a multi specialty outpatient practice, all these different sizes of organizations, I'm still constantly seeing that there are issues with telehealth services. And it's happening not only from the documentation side, but when I start to talk to them about things like their workflow, for example, I'm finding that even the structure of how they're intending to use it is broken. So, can you just start a little bit, Michelle, from your perspective, giving some insight into what it is that you're finding right now from, let's say, the documentation side of things? So, what it's looking like when you're doing your audits.
Yes, so I think right now the biggest finding that I am having is people are still trying to apply old thought processes and verbiage, especially in that area of audio only. I know with these new guidelines and deleting those audio only E&M codes, that has really caused, I think, the biggest point of confusion surrounding the telehealth services. So when we're looking at telehealth going forward, until, obviously this is just an extension at this point, but for the extension period, we have to look at what are the new requirements. So just like you said, Stephanie, we have to be looking at not only what CMS is telling us, but also our local payers. So you're going to have to do some research to see what are going to be the requirements now that those audio only codes are no longer there, which those have been gone for a couple months now. But we are still seeing some of that confusion and some of those issues. So you want to make sure that you're not applying old thought processes or old verbiage or old guidelines to the new workflows that we have in front of us. I think that's the most important thing with the changes and then also the extension. Just kind of like how we still see in telehealth statements that telehealth is being used due to the COVID-19 pandemic. That's not really the purpose anymore. So we want to make sure that we're taking a look at what's being documented and that it actually is fitting what now the services that are being provided, and that we are following the new format and new guidelines accordingly, using the correct codes, correct place of service, correct modifier according to the different payers. And I do think that the resource you put out there with those worksheets will be extremely helpful, just to kind of streamline that and just have one place for people to kind of take an overview of their major payers and see what the requirements are and how they differ, and what we need to do to ensure that things are getting billed appropriately to those guidelines.
Yeah. And, that's one thing too. So if we think first about documentation, like you said, it's been problematic seeing the statements related to COVID. One of the other things that I find, which can be pretty scary, is that there's still organizations who are doing telehealth and they're not even saying it in the note,
Yes.
meaning we have no statement. During the PHE, I was seeing that a lot. But now that we have this more permanent version of what this is going to look like to some extent, it's even more problematic that we don't even have this indication. Sometimes when I'm doing an audit, I know that the visit was telehealth because I can see a schedule, for example, or because I see a modifier's been added. But outside of those indicators, the actual progress note is not showing any indication. And, I know that we've all seen, and I'm sure our listeners have seen as well, the situations where we have our practitioners using the same templates for this as well. And it's resulted in things like a physical exam being populated that cannot even physically be done in that format, things
Hmm.
that are
Yeah.
hands-on. I think one of the funniest examples I've seen over the years that we've been dealing with this was a situation where the template being added was for some reason specific to female patients. And the not only did they say that a pelvic exam was being done, it was specific to the female anatomy, and it said it was being done through telehealth. So, we really have to make sure that, it's not just the same old where we're just continuing to say, oh, okay, this is paying similar to a visit in the office if video is used. Especially during the PHE, we had a lot of that happening
Hmm.
where reimbursements, payers were trying to make sure that reimbursements were similar or the same as in the office, depending on the way that telehealth was conducted. So I feel like, there's different pieces of that where people will listen to portions of it, but we haven't had this complete overhaul inside of many of the organizations where you're pausing, taking a look at it, and making sure that we have everything that's needed. Now, one of the main things, Michelle, that I've seen with the ones that do have a telehealth statement is that we don't have the different identifiers that are going to show us some of the specifics that are required now going forward. So, what I mean by that is you had mentioned, for example, the place of service can differ depending on whether the patient's home or away from home.
Yes.
That type of thing is going to have to be within a statement. How else is that going to be known unless that's located inside of a macro statement? So, one of the things that I've been suggesting, and this is also on the guide that I mentioned that you can download on the
Hmm.
website. In there, there's some framework for macro statements that you can build off of. And, it starts out with identifying the fact that you have patient consent. And I want to pause there and talk a little bit about consent because, this is something where I do think some of our providers are not understanding this completely because we still are dealing with people that are thinking, oh, I called the patient to talk about a normal test result, so I get to bill for that now because telehealth services are covered. And, that's problematic in itself from a medical necessity perspective. The
Hmm.
patient has a right to know their test results. It is not active management to tell the patient their test results. A lot of practices now have portals where they can view those results, and we don't have any action items needed based on, abnormal findings. I felt the need to throw that out there just to make sure. We need to make that clear.
I
But
think that,
go ahead.
you explained it to me very well, back when all this telehealth stuff was ramping up with COVID, and I was like, "But, they did this, they did that, and it looked like a good visit," but then you pointed out to me, if it wasn't something that they would do prior in the office, prior to telehealth, why would we now, because telehealth is available, consider that to be a billable encounter? Meaning something like reviewing test results. They probably would have just called them before. They wouldn't have necessarily brought them back into the office to say everything looked good. We'll see you in another year. Or patients needing a refill on a prescription. I know that's a big one that I see too. So kind of think of it that way. If it was something before all this telehealth that started becoming so widely available, it's probably not something appropriately to bill under telehealth now.
Yeah, and that can also go into the workflow side of things too,
Hmm.
because prior to the PHE, a lot of times it was the nurses in practices who were calling to give updates on normal test results. And again, normal results mean that the patient doesn't require any follow-up treatment at that point typically, or any additional testing. It's like you said, the findings are okay. We're good now. We'll follow up as scheduled, as discussed previously. So that was usually done by clinical staff, typically nurses prior. So we had this shift where, yes, when practices were shut down or when volumes were much lower, we also had all these problems arising just due to organizations looking for reimbursement, right? For billable
Hmm.
encounters, things like that. So it's really become an issue in that particular way where these bad habits formed and now they're still sticking around. So ultimately, getting back to consent, when you have that situation where the practitioner is reaching out to the patient has not scheduled the visit, the patient has not called and asked for this, we don't have that base underlying component of that patient consent. And the reason that patient consent is needed too, if we take that even a step further, this is something where they're going to have out of pocket costs typically, right? So
Hmm.
this isn't something where it's going to be paid and the patient's never going to know that you billed this to their payer. This is something that's going to be very similar to other in-person services with co-pays, deductible, co-insurance, whatever it may be. So consent's going to be huge in that patient education. We need to make sure that the patients are aware as well that when they are scheduling this type of appointment, that this is a situation that replaces the in-person visit and it is billable and they could have out-of-pocket costs. Michelle, one of the things I think about too, every time we talk about patient consent, really that informed part of it where the patient's aware of what that means to them. And
Hmm.
really, we want them to have that option. Maybe they really are frustrated with virtual. They don't want to have a video visit. They feel like it's not, as thorough. They would have preferred to come into the practice.
Hmm.
Those are the type of things that need to be discussed so that it's all clear up front and what would really be a part of fully obtaining a patient's consent for that service.
Yes.
Now, another part of the statement, and a large part of the statement, is identifying whether the encounter is interactive with video used or if we have an audio only encounter. And this is something that has really been problematic over the years, still currently is an issue, just based on the fact that we have so many different ways that providers are referring to this video component. So, what I mean by that is, for example, I'll see notes that say this was a virtual visit or this was a visit on doxy.me. They'll name
Hmm.
the actual platform, But we have to remember, first of all, we don't have, actual definitions from a payer that says that if you use this particular word, it means video. The word video means video, but the word
Uh-huh.
virtual, we don't have that written anywhere in policies that virtual, distinctly means video used. So we have to be careful when we think from that perspective. And, in this situation, it's something where my mind's always going back to that defense side and what we can look at from written guidance, written policies to support and defend in an area like this. um, when we think about the platforms, for example, those have the capability of still conducting a visit as audio only. So just because somebody's using doxy.me, or there are different platforms that have now implemented HIPAA compliant software, I guess I'll call it,
Mhm.
like Zoom, and I think Ring Central. There's these different ones we would think of that were just typically for meeting platforms, but they have gone a step further, created HIPAA compliant software that can be purchased and used for the visits. So just stating the platform alone is also not going to be enough. Michelle, are there different ways that you've seen that, or what do you typically work through with this component of trying to figure out, video versus audio only?
Yeah, my recommendation is typically to just say it. Um, I mean, like you
Yeah,
said,
pretty simple, right?
from a defense standpoint, there's only so many ways you can say video. There's only so many ways you can say audio only to explicitly convey the technology that was used for that particular visit. And if you're not identifying that, it's going to cause problems with how does it get billed? Because you've got to know for different payers based on modifiers and things like that, or even the CPT code set that needs to be used. So you can't just make the assumption that, like you said, because you've said virtual or because you've said a specific platform was used, that it automatically means video was used. So my recommendation is always to just have documentation that explicitly states video or audio only was
Mhm.
used for the encounter, because then it doesn't leave anything up to question. And I think something that makes the whole telehealth statement um, difficult to educate and convey is that we don't have a set standard or a set guideline out there for
Yeah,
what
across the
has
board.
to
Yeah.
be documented. So, a lot of these things that we are looking for would really be considered a best practice. And you have to look at it not from the standpoint of what's the guideline, what is required, but how are we going to support this telehealth visit? And how are we going to show that we met all the requirements to bill this? And it comes down to what's documented in the telehealth statement, regardless of what policy or guideline may or may not be out there. It's from a defense standpoint, as you had already noted when it came to video or audio. So I think that's something really important to keep in mind too when you are trying to develop policies, and even maybe you're trying to create a template for your providers or give education. Remind them that it's not necessarily about a guideline that's out there, but actually proving that what you're saying and billing for happened.
Yeah, so I want to clarify that a little bit too, because I know exactly what you're saying, Michelle, but I want to clarify for some of the others out there what she's referring to. And I mean that because a lot of times we'll get asked, for example, well, where does it say that? And if we have a variance on an audit, we'll get pushback where they don't agree with the finding unless we find something in writing that dictates these things must be documented. So, what Michelle is referring to is that we do have guidance out there, we do have
Mhm.
policies that specifically says what needs to be done, but we're not always going to have that spoon fed to us in a way that says, documentation requirements with a bullet point list of what a payer is expecting to see documented. So it's one of those things where, to have that proof of what's done, we want to see that in writing.
Mhm.
And, I think a good example of this too, Michelle, is during the PHE. I remember, it was frustrating because our information was changing on a regular basis. And one of the things that came up was this patient consent. And it bothered me that it kept saying, no written consent is needed. You just need verbal consent. So I'm thinking, okay, well, what's going to happen in the event of an external review? And sure enough, we had some clients where initially they had some telehealth audits being done, and the first round was showing a very high error rate because they said there was not patient consent. So, yes, we went into CMS documents and guidelines and proved that it only had to be obtained verbally. No, it did not say that the provider needs to document verbal consent was obtained, but it still created this situation that had to be defended, even though we were right at the end of the day. So, to Michelle's point here, when we have guidance that says what needs to be done, remember that our note is that receipt of what occurred. So,
Mhm.
that's why we need to have this over into documentation, because otherwise you're going to be creating situations that are going to have to be defended. And it's not a question of whether or not you're ultimately right in the end, because remember, defense comes with a lot of money attached to it, right? A lot of
Mhm.
time attached to it. And you've got to have these things in place up front so that when you have the external review, it's very clear what was in place, it's very clear what was done as it pertains to the guidance we do have. And, hopefully that will result in just passing through the audit process with no issues. Now, one of the other things too, so getting on from all of that, is the patient location. So this is something where a couple of things. I've been asked about, how specific somebody needs to be in their statement, for example, to say that the patient's away from their home. And again, this is another area we don't have dictated guidance that says you must identify, the address of where the person is or a specific name of where a person is. But something we need to think of from a workflow perspective first that will impact this is making sure that the patient is physically located in the state where the practitioner has the licensing. And this is something that's been really difficult from a patient education standpoint. And what I mean by that is, we have a big shift now in the professional world, right? A lot of organizations allowed remote work during the PHE. It has continued to stay that way. And we have people who travel, whether it's for work, maybe they want to live in other states different times of the year, they're on vacation, they're away at college. All these different things happen. And there's still this large misunderstanding that the patient just has to have insurance. This is something I've been told. They thought that the patient just had to have insurance in the state where the practitioner is licensed. And, we have to be careful because we have to think about where that visit is essentially occurring. And when
Mhm.
the patient's out of the state, they're not receiving that service within those borders of that state. So this is something that needs to be looked at from an internal workflow perspective, because
Mhm.
what does your provider do if they're on a call and they find out that that patient's in a different state? But also, what have you done to notify your patients? If you're still utilizing telehealth, you've permanently brought that in as a service line. What have you done to then educate your patients about where they have to be at the time of the visit?
Yeah, and I think that workflow is so important because a lot of this can be flushed out before the provider even gets to the visit with the patient. I actually had an indication, and this is kind of a reminder that even when you do set up a template or a smart text or something for things like a telehealth statement, you have to continually review it to make sure that it is pertinent and that it matches the service that was provided. I just this week was working on an audit, and the provider answered all the telehealth questions just like, great patients at their home, all these things. But then as I'm reading the HPI for this visit, the patient's in a completely different state across the country. And they are not, in fact, at their home receiving this telehealth visit. So that was not supported. But from a workflow perspective, when these are being scheduled, that should be something that's being asked. And then make that more of a verification for the provider than finding out that information at the time of the visit. I think
Mhm.
that if you are kind of proactive in that sense, knowing that the patient has to be located in the state where the provider is licensed to provide care, if you're verifying that when the patient is scheduling a telehealth visit, you're going to catch those things before it gets to the point with the provider more often than not. There's probably still some that will slip on by, but I think that workflow is extremely important to make sure that that particular portion of the telehealth requirements are met.
Yeah, and one thing too, so on the PDF that you can go onto my site and download, you can look at the very last page of that, and I have a website there that I want you to take a look at. It's CCHP, so it's Center for Connected Health Policy. And one of the things that's in there, oh, also one other thing, you can go to HHS's website, which I have that link in there as well. These are important because there are also now different options for what's called compact licensing, and it is specific to certain practitioners, so it's not necessarily going to be available across the board. But one of the things that I found, for example, I have a client in Massachusetts that has a large population of patients, all mainly telehealth services, and a lot of the patients go down to Florida for the winter. So one of the nurse practitioners found that she was able to get a limited license for telehealth, and the process was actually pretty simple. The cost was not very large. So there's different ways to do that. You can look to individual states if you have patients who travel to another one often, or you can go ahead and take a look as well at the options for compact licensing, which just a high level overview of that. Once you have a compact license, there's different states that have agreed to join within this. So if you are practicing within that network of states, you are covered from that medical license standpoint. All right, now we have a comment here I want to bring up. Jordan was just saying that there is situations he's already been a part of where he's participating in litigation around this particular area. So, yes, and that's something too, like I was saying before, from the defense standpoint, you know, things get very limited depending on what somebody's done and what we're able to look at. And a lot of this is just stemming from people not doing their due diligence, not even knowing where to begin. I understand that can be really difficult, but it's something that you've got to pause, you've got to take the time because the risk is going to be very large. A lot of what we want to focus on from the compliance perspective is mitigating that risk and finding these areas that are going to be a potential problem. And the only way to tackle this is to go over everything and pay attention to changes. I know we say that a lot.
Hmm.
Things like this podcast, other podcasts out there, Sean Weiss's podcast, Compliance Guy, Terry Fletcher, she has her podcast, The Codecast. Christine Hall has hers with Sterling Global. There's so many different resources out there, but also in different forms of media now, which I'm really liking. For me, if I'm in the car or, working, I like background noise. It's
Hmm.
easier to put these types of things on. So we've got to stay up to date because it's the only way we're going to be able to tackle, these types of issues.
Yeah.
Now, getting back to the comment I made about where the patient's located, I just want to say one other thing. So I had mentioned that I've been asked sometimes if you have to put an address. For example, let's say the patient's at work. Do you have to put an address in there? No, you don't necessarily have to put an address, but you've got to identify where that patient is. And you want to keep in mind too, I think it was United Healthcare when we started to see some more permanent policies come out on the commercial side. There had been a policy or a statement released that said the patient has to essentially be in a clean, tidy location. And it's like, obviously we're not going to go to that extent, but what I took away from that is it needs to be a private location, right? We're
Mhm.
still we're still dealing with sensitive information. I have some practitioners that patients will join the call or the web. I want to say webinar. It's not a webinar, but if they're using the platform, the encounter, they'll join the session and they're in line at the grocery store. Or, Michelle, I think that you're the one who told me about a practitioner who was treating their patient and they were in line at Chick-fil-A and the patient could
Yes.
hear their order in the
Yes.
background. So, let's use some common sense. It's one of those things where I would hope I wouldn't have to have this conversation with somebody, but, we have to from time to time. So we've got to have that privacy there. And one of the last things I want to bring up in regards to documentation and the way that the macro statements are going to be noted is the situation when video is not able to be used for the majority of the encounter. And this is going to go into what we'll talk about next as well with the coding piece of it. But this is something where if that patient tries to connect with video and the connection is lost or whatever happens, you're not using video the majority of the time, it's not appropriate to then document that video has been used for that whole encounter.
Mhm.
And I know from an audit perspective, Michelle, a lot of times we'll see the providers show us that video was not used.
Yeah.
Um, but we have to remember that that then means we have to go the route of the audio only options of billing at that point. Now, getting into the piece related to coding. So there's a lot of moving parts here, I feel like, just because, again, this is not something we can give answers to everybody that's going to cover
Mhm.
every payer because they all pretty much get to decide what they want to do within the set of modifiers and place of service and CPT codes that we have, right?
Yes.
But we have to be aware of where things are at now. So I want to start out first, Michelle, talking about 99441 to 99443. And I laugh a little bit there because this is something where I'm still seeing the codes being used.
Mhm.
So, I'll be asked, why are we getting these denials? Why is this not reimbursing? And it's because the codes were deleted at the end of the year.
Yes.
So we have this conundrum basically right now we're dealing with where AMA chose to delete out that code set. So for anyone who's not aware of what those CPT codes are, and scary enough, I still work with practices that didn't know they existed even when they were supposed to be using them. But the 99441 to 99443 is the specific codes we had for telehealth E&M audio only services, telephone, I should say, not telehealth. So an audio only E&M service, and those were time based. And at the end of last year, those were deleted out of the code set. AMA introduced new codes that were implemented January 1st of this year. I'm not going to go over the specifics of those CPT codes, but they are in the guide again if you want to
Mhm.
go and download that. Um, but CMS pretty much said, the new code set is redundant because if we look at it, we have options for new or established patients. We have the option that identifies whether it's video and interactive or audio only. And we also have the medical decision making or time component, just like we do with the other set of codes that we use, especially in that outpatient setting. So, Michelle, what has been your experience? Because I know for me, it just, it's kind of like the luck of the draw at this point when I'm doing my audits. It's not something where I can sit down and know automatically that, maybe a client isn't using the new code set and they should
Mhm.
be.
Yeah, so I think that the best thing to do is just have a conversation with the client and see where they're at with these new codes. If you haven't already, I would definitely recommend creating some kind of matrix for your own coding use. So if you are within a coding department, do the research, create your own type of matrix for what the different payers want, what codes they want you to use, what modifiers they want you to use, because this can get pretty confusing very quickly. And make sure if you're creating those resources and you are having outside auditors come in, share those resources with them because that saves us a lot of time on the back end. I know I'm working a project currently where there was I didn't receive the matrix, so I was left to do my own research, and I did not come up with the same information they had. And they're like, "Well, we have this matrix." And it's like, "Well, this would have been really nice from the
Yeah,
beginning."
up front.
Because still as an auditor, I do try to obviously we're never going to be able to know every single payer's individual policy and recommendations, but it's fairly easy to go out there and find this information. I say fairly easy, but sometimes they make it really difficult. I will recognize that. But my recommendation would be to just take the time, create a matrix of what's required for the different telehealth scenarios. Include the CPT codes that they want you to be using, the modifiers they want you to be using, the place of service for the different scenarios that they have out there. It will save you a lot of trouble in
Mhm.
in the long run with things like denials and such because you'll be submitting it correctly the first go around. Like you said, Stephanie, some people are still using the codes that have been deleted. That's going to create an automatic denial. That takes time, that takes money to reprocess that. So make sure that your systems are updated. I know that even in systems like Epic, you can create payer logic in there to automatically change if something's been added a certain way. The payer logic can be updated to change it to the
Mhm.
correct billing scenario based on what's been entered for that particular payer. So make sure that you're reviewing all these things to avoid those denials. There's nothing worse than an avoidable denial just because of how costly they are. It does take some time on the front end, but definitely do that research, get the matrix made so that everybody's on the same page.
Yeah, and one thing with that on the whole concept of being on the same page, we have to remember too that even if an organization has coders, we also may have a completely separate billing team, right?
Yes.
So whether they're dealing with just the back end AR or if they're helping upfront with some of the claim edits that happen at the time of scrubbing, everybody needs to be on the same page and know that information. And that's one of the things too with the telehealth statement suggestion that I have. That's been set up in a way where it's going to cover the various different components that could potentially come into play. So
Mhm.
you had mentioned place of service. By putting into that macro statement, whether the patient's home or wherever they're at, if they're away from home, that information needs to be somewhere because whether it's a coder or a lot of organizations are not employing coders, even large hospital facilities.
Mhm.
So if you're putting that on the provider, a lot of times the billing team will come in and they will take care of adding in appropriate modifiers and changing place of service. So it's all interconnected. The
Yes.
workflow has to be right. We've got to make sure we have documentation that's appropriate, and then making sure that we have, correct resources in place to direct everybody appropriately. Now, with that being said, one of the things I know, I've had a conversation with a good friend of mine, Pam Vanderbilt. She owns her own billing company. And, we've talked some about this and whether or not she's seeing a high volume, for example, of payers who are wanting the new code set. And, again, it's going to depend on where you're at. But overall, even in my own reviews, I've not seen a high volume yet of payers that are wanting this particular set of codes. So I think it's going to be something that, we're going to have to get more comfortable with. We need to
Mhm.
make sure that, we have the codes available in the system. To your point, Michelle, we got to make sure we're checking with our vendors. With the 99441 to 443, you don't want to completely delete codes because you could
Mm-mm.
have situations of older dates of service you need to deal with when they were active at that time. But there's different things that sometimes the system can do to display, maybe, for example, the new set of codes, or,
Mhm.
not allow the other one as an option to even pick from on current dates of service, things like that. Now, do you have any suggestions, Michelle, from your perspective as an auditor? What are you thinking of from like a process improvement perspective? Maybe even it's something that you wish you were seeing more more broadly at this point or at a higher frequency when you're working with clients. What insight do you have there as an auditor?
It's very similar to what I said earlier, in that you have to stop thinking about the old the old guidelines and how we did things before with the audio only in particular. I know I keep going back to the audio only, but that's where we have the biggest change, with the deletion of those codes. My recommendation really starts with your workflow. Start from the beginning when patients schedule, and then going right through the steps, reviewing what templates are being used, and reviewing that process. Who's reviewing these claims after after the provider's completing their documentation, who's selecting the code, making sure that the appropriate education has been given to everybody who is involved. Because I think that a lot of times we don't realize the range of people that need to be in the know. And we've kind of already talked about that. But even your front end staff, the people who are taking those phone calls to schedule these appointments, need to know a certain level of the rules and guidelines to try to help mitigate some of these things right from the beginning. And
Mhm.
we talk a lot about coding and auditing and billing and that side of things, but a lot of this can be prevented or mitigated just by asking some questions when the appointment is being scheduled. So
Yeah.
I think starting right at the beginning, and with all of the changes, it's a really good time to do a kind of a comprehensive review of what you're doing with your telehealth. It's a good time to roll out training and reminders, new a new process if that's necessary for your facility. It's just a good time when there's change. You're not necessarily going and saying, "Oh, you're doing something wrong. We're coming to you because this has changed and we need you to make sure that XYZ is taking place, to make sure that everything is being done correctly and that we are in compliance with telehealth." I think that's the biggest thing, is that everybody has the information necessary to do their job and do their job correctly.
Mhm. So, really quick here, we have a question in the comments that I want to address as well. So, Teresa Kelly said here, quick question: if there is time for patients that are at a different location other than home, we have a macro statement that states home or other, and the providers check a box. Are providers required to document the specific location, such as a vehicle, if they check the other box? Thank you. So, this is a really good question because this is an example of what we were talking about a little bit ago in relation to the fact that we still don't have very clear guidance as to very specifically what they want to see. Now, when I'm working with clients, what I would prefer to see is more information than just saying other. Because the question could be, well, if they weren't home, where were they? So, for example, like you said, vehicle, a lot of people will take a call at work, maybe go into a separate office space, a separate conference room, a private space, and do that there. So I do suggest that there's additional information said.
Mhm.
Could I go somewhere and tell you that that is absolutely required and it must be there? No. But when we're thinking best practices, we're looking at how you're setting that up. It's a good idea to put that in there. Now, one other thing I have found interesting, and I can't recall the payer or the particular state at this point, but I have seen some information come through where it's questionable, for example, if the patient should even be in their vehicle. So, that could be from the whole privacy perspective, from a safety perspective, hopefully that patient is pulled over in a parking
Mhm.
lot. But that's just something to think about too when you're doing your research. You want to make sure you're looking to see if there are any of these crazy restrictions, just like that clean and tidy space.
Yes.
We're not going to say we can't do your visit today. You didn't pick up the room you're in.
You didn't do your dishes.
Yeah, put the laundry away. But realistically, I would want to see something more than just saying other so that we know what that other is.
And I think something to when you're educating your providers on this whole location portion of things, they're trying to validate that they're located in the state where the provider is licensed. It's not necessarily where are they sitting. A vehicle could be anywhere. You could say your patient's in their vehicle and they could be 3 states away sitting in their vehicle. So it's more about checking that box that they are in the state where you are licensed to provide care, and not so much, what building they're sitting in.
Yeah.
So
Yep.
vehicle, like you said, it's just a very broad response. So when you're educating your providers on that other box, they need to have some kind of specific documentation to show that they're in, like, I'm in the state of Florida, for example. If I was seeing my doctor through telehealth, I would expect them to show somehow that I am in the state of Florida or be able
Mhm.
to prove that I am in the state of Florida.
Yeah. And we want to remember too, of course, this is going to be more of an extreme situation, but if you didn't realize, payers actually will go out at times and interview their own members. So if
Mhm.
they have questions, they're going through an investigation. Let's say an SIU department is investigating a practice, and there's a lot of questions about maybe their telehealth, there's high volume services, or whatever triggered this investigation. They can interview their own members as well to say, hey, where were you for these dates of service? Do you live in this state all the whole year?
Mhm.
There's different ways that that can be found out. So that's why it's so important to make sure that your workflow is solid and that everybody understands why. And the other thing is too, we focus on compliance as it relates to coding and billing, but this is a legal issue too with the medical licensing. So
Mhm.
that to me, hopefully would be even more of a concern if you struggle to get your providers to understand it for the billing side of things. Hopefully they would take that, more seriously if they understand that, okay, this is actually considered practicing without a license, which is a problem.
Mhm.
So,
Yes.
yeah. Um, Now, really quick to end all of this out. Like you were saying, Michelle, as far as the research, all of that goes, all we can do is dig in at the level of every payer. But as a starting point, what I like to suggest is if you are billing to Medicare, for example, absolutely go to CMS. One other clarifying piece on that too that I forgot to bring up before, when I was saying that CMS is not accepting the new code sets that we have specific to telehealth and audio only, right now, what that currently means is we have to utilize the code set for where the patient would typically be seen if they were seen in person. So this
Mhm.
happens a lot in the office. We have our 99202 to 215, and you would be appending the 93 modifier if that patient's seen audio only. One other thing that I want to point out that you need to pay attention to if you're going to go back and start researching is that some payers are no longer allowing audio only. And that's
Mhm.
another thing, that has been somewhat surprising to some of the clients I'm working with. And, if they have that written policy and they come back wanting to take back money on what they've paid out because you billed it all as video used and actually it wasn't, that's going to be an issue. And I've unfortunately been having to work with some organizations through similar things like that. Now, lastly, we talked a little bit about the platform, but I want to highlight one more thing because this is very important. And I just had this conversation 2 weeks ago with somebody. The platform you're using has to be HIPAA compliant. You cannot just use your iPhone. You cannot
Mhm.
use FaceTime. You cannot use, Facebook Messenger, whatever it may be. You have to have a HIPAA compliant platform. So if you don't have that in place, you can research it really easily on Google. There are different options available, but I would also say check with your EMR vendor because there have been vendors that have been implementing these different tools for you to use that are directly, integrated into what you already have set up. So
Mhm.
make sure you're checking all of the areas and do your research. I'm going to put this up one last time in case you weren't here at the beginning. So you can go to stephanieallardconsulting.com. On the homepage there is a free telehealth resource guide and worksheet. So this has an overview of the specific detail related to codes that are out there, my suggestions for documenting the telehealth statement, what that should look like, the modifiers, the place of service, and then a worksheet where you can, utilize that to actually jot down what you're finding out with the different payers. And
Mhm.
on the very last page, I had mentioned in the middle here, there's the websites related to those licensing, the compacts. If you go into those state sites or the CCHP, for example, you can look up the states you're in or that your client is in, and it's going to give you an overview of where telehealth is at from the perspective of the state you're in. That's another thing we really didn't break down. It just keeps coming, right? But
Yep.
that's another thing to be aware of as you research is that we have to know not only the state or the payer requirements, you have to be aware of what everything is set up in the state you're in, the telehealth laws. So,
Mhm.
Michelle, I know with you being in Florida, you've told me there's certain things that, can't be done through telehealth just based on state laws. So it's a lot. It can be overwhelming. Break it down to CMS if you participate with them, and then pick maybe your top 4 or 5 payers from there, and then see what comes up as time goes on with, other payers that you may not have as high of a patient volume with. But
Mhm.
cannot stress enough, there's not going to be anybody who can hand you a package unless you're paying them to do this research. This is something that you want to be on top of. The CMS extension is through September 30th. So we'll see after that what this is hopefully going to look like more on a permanent basis. But right now, we do have a good starting point, and we have a lot of the commercial payers that, have more solid guidance for us in their policies. So take a look. I hope you find the resources there helpful. And as a quick reminder, if you can go to whatever platform you're listening in on, if you can like this podcast, like the episode, subscribe to it, share it, comment on it, rate it, review it, any of those things, that's definitely going to help getting the word out there and growing the podcast. So I thank you for joining us this week, and we will see you back next Wednesday.
Thank you.